When it comes to mesothelioma, there isn't one standard surgery. There are different surgical procedures with different goals, different risks, and different outcomes. The best surgery for you depends on whether you have pleural or peritoneal disease, the stage your mesothelioma has been diagnosed as, your overall health, and what you're hoping to achieve. Today, I want to explain the different surgical options for mesothelioma, how to decide which is right for you, and how to find surgeons with the expertise to perform these complex operations. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice. But understanding surgical options helps you make informed decisions about your care. So let's start by separating pleural mesothelioma surgery from peritoneal mesothelioma surgery because they're completely different operations. For pleural mesothelioma, the two main surgical options are extrapleural pneumonectomy, or EPP, and pleurectomy decortication, or PD. Extrapleural pneumonectomy is the more radical option. In an extrapleural pneumonectomy, your surgeon will remove the entire affected lung, all the pleura on that side, part of the diaphragm, and the pericardium around the heart. These structures will then be reconstructed using synthetic materials. An EPP is a massive operation that lasts 6 to 8 hours, and it comes with significant risks and a difficult recovery. When EPP was first introduced, the rationale behind it was that removing everything, including the affected lung, would eliminate more of the cancer than would be the case if the lung was left in place. However, the MARS-2 trial showed that EPP did not improve survival compared to chemotherapy alone and often made quality of life a lot worse. After the results of that trial were published, most mesothelioma specialists moved entirely away from EPP except in very select cases. Some centers still do perform EPP for carefully selected patients, but it's no longer considered the standard of care by most experts. Now, before I go on to other surgeries, I want to take a break and ask you a favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comment section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. The next kind of surgery for pleural mesothelioma is called pleurectomy decortication, or PD. Pleurectomy decortication preserves the lung, but it removes the pleura and all the visible tumors. Your surgeon will carefully peel the diseased pleura off of the lung surface, remove tumor nodules, and clear all visible disease from the chest wall and diaphragm. PD is still a major operation. It lasts 4 to 6 hours, but recovery is generally easier than for EPP because you're keeping your lung. The goal of PD is maximal safe tumor removal while still preserving your lung function. Complete removal of all tumor disease isn't possible, but reducing the tumor burden can relieve symptoms and potentially extend survival, especially when it's combined with chemotherapy or immunotherapy. Evidence for the benefit of PD is stronger than for EPP, though it's still not definitive. Some studies show improved survival when PD is part of a multimodal treatment plan that includes chemotherapy and sometimes radiation. So, which pleural surgery is better? The current consensus among most mesothelioma specialists is that PD is preferable to EPP for patients who are surgical candidates. PD preserves lung function, has a lower mortality risk, and easier recovery, and is at least equivalent, if not better, survival outcomes. But not all patients with pleural mesothelioma benefit from either surgery. Surgery is only considered for patients who are in early stage disease, who have epithelioid cell type, are in good overall health, and disease that imaging shows to be resectable. Even then, making that decision requires careful consideration because their outcomes are not so great. For peritoneal mesothelioma, standard surgical treatment is cytoreductive surgery combined with HIPEC, which stands for heated intraperitoneal chemotherapy, and that's a completely different type of operation. Cytoreductive surgery involves opening the abdomen and systematically removing all visible tumors. This might include removing the peritoneum from various regions, removing the spleen if it's involved, removing parts of the bowel if tumors can't be separated from it, removing other involved organs, and clearing tumor nodules from organ surfaces. The goal is complete cytoreduction, which means removing all visible disease or reducing it to tiny nodules that measure less than 2.5 millimeters. After removing all that visible tumor material, HIPEC is performed. In this, the abdomen is filled with a chemotherapy solution heated to about 108 degrees Fahrenheit. It's circulated for up to 2 hours with the goal of exposing the tumor to the heat and high concentration of chemotherapy that would kill any microscopic cancer cells left behind. This is a massive operation. It lasts 8 to 12 hours and requires about a week of recovery in the hospital. And it'll take several months before you can return to normal function. There are significant complication rates, including infection, bowel complications, and other issues, but the results can be excellent, especially if it's performed at an experienced surgical center. 5-year survival rates have reached 50 to 75% for carefully selected patients, and that's dramatically better than outcomes without surgery. Now, that key phrase is carefully selected patients and experienced centers. Not everyone with peritoneal mesothelioma will be a candidate for the surgery. Eligibility requires the patient's disease to appear completely or nearly completely resectable, and preferably it should be the epithelioid cell type, for there to be no distant metastasis beyond the abdomen, for the patient to be in overall health that's good enough that they can tolerate a massive surgery, and for treatment to be performed at a center that performs many of these procedures each year. How do you know which surgery is best for you? First, determine if you're a surgical candidate at all. Many patients aren't, and for them, systemic treatment with chemotherapy or immunotherapy is the appropriate approach. If you're a potential surgical candidate, get evaluated at specialized centers, more than one if possible. Different centers have different surgical philosophies and approaches, and getting multiple expert opinions will help you better understand your options. When you're meeting with physicians, be sure to ask specific questions, including, what surgery do you recommend and why? What are the alternatives? How many of these surgeries do you perform each year? What are your survival outcomes and complication rates? Is your goal with me to try for a cure, to extend my survival time, or to provide me with relief from my symptoms? What will my recovery look like? How will surgery be combined with chemotherapy or other treatments? For pleural mesothelioma, also ask, why should I do PD versus EPP or vice versa, or why surgery at all versus chemotherapy alone? How do outcomes at your center compare to the MARS-2 trial showing EPP didn't help? For peritoneal mesothelioma, ask, do you think complete cytoreduction is achievable in my case? How does the extent of my disease compare to other patients you've operated on? What's your complication rate, and how do you manage those complications? Be cautious about surgeons who aren't open about their statistics, and especially about those who promise a cure. Experienced mesothelioma surgeons are realistic about what surgery for this complex disease can and cannot achieve. If you're being evaluated at a community hospital by a surgeon who rarely performs mesothelioma surgery, go and get evaluated at a specialized center before making any decisions. The volume of cases a center sees matters enormously for outcomes with these surgeries. For peritoneal mesothelioma especially, you want a surgeon who performs dozens of cytoreductive surgery with HIPEC procedures per year, not a few. The learning curve is steep, and outcomes are much better at high-volume centers. To review, which surgery is best for mesothelioma depends on the type of disease and its location. For pleural disease, pleurectomy decortication is generally preferred over extrapleural pneumonectomy, though many patients aren't surgical candidates at all. For peritoneal disease, cytoreductive surgery with HIPEC is the gold standard for eligible patients, and it offers dramatically better outcomes than non-surgical treatment. Go get evaluated at specialized high-volume centers. Ask about surgeon experience and outcomes, and be realistic about your goals. You can visit mesothelioma.net for more information about mesothelioma surgery and about where to find specialized centers. Or you can speak to one of our patient advocates right away by calling 1-800-692-8608 or using the live chat feature on the website. As for me, remember to post your questions below, and I'll see you next time.